Good evening, guys. I've got B for you. Articles discussing assisted dying. Since it's a hot date for countries, certain states in the U.S. for terminally ill patients. So I thought I'd discuss that because people are proposing different laws and things about end of life assisted dying. So we're gonna go through that this afternoon for discussion B. So here we go. Please join me in tonight's discussion B. Here we go. The article reports that the UK House of Commons has passed the assisted dying bill, a major legislative step that allows terminally ill adults with less than 6 months to live choose to end their lives legally. The bill passed by a narrow margin, 314 to 291. Further debate and now proceeds to the House of Lords for further debate. Security. The key reactions include hospice leaders express deep concern, warning of huge implications and a potential seismic shift in end-of-life care. Jan Noble, a interim chief of St. Christopher's Hospice, urged the government to ensure proper funding and support for hospices, emphasizing the need for high quality care regardless of legal challenges. The hospice community is maintaining a neutral stance on the law itself, but calls for careful, inclusive deliberation, especially considering people affected by health inquiries. If you'd like, we could explore how similar legislation has played out in other countries, or discuss the ethical tensions it raises for healthcare professionals and caregivers. The passage of the assisted dying bill in the UK House of Commons carries wide-reaching implications for end-of-life care, both practical and philosophical. Refining autonomy in dying. This legislation introduces a legal framework for individuals with terminal illnesses to make a conscious, supported choice about ending their lives. It could shift the narrative from passive to more proactive control over dying, reframing what dignity means in one's final months. Okay, pressure to pressure on palliative care or palliative and hospice services. Hospice hospice leaders are signaling concern that this may divert attention or funding from holistic palliative care. There is a fear that legal access to assisted dying might inadvertently reduce investment in pain management, emotional support, and family-centered care unless partial community commitments are made. Ethical crossroads for healthcare professionals. If the law advances, clinicians and support staff may find themselves grasping with profound ethical questions. Even if participation is voluntary, the presence of this option requires deeper conversations around moral distress, consciousness, and objection, and the evolving role of medical guidance at the end of life. Equity and accessibility concerns. There are critical questions about how this law could affect those already experiencing healthcare inequalities, such as people with disabilities, limited English proficiency, or poor access to medical resources. Advocates stress the importance of ensuring the law doesn't exacerbate discrepancies or become a default path for the unserved. Societal and cultural shifts. Over time, legislation like this may influence how society perceives aging, dying, and caregiving. It invites public reflection on quality of life versus longevity and may shift how families and communities engage with terminal illness. If you're interested, we could explore how countries like Canada, the Netherlands, and New Zealand have integrated similar legislation and what outcomes they've seen. Their experiences could offer helpful parallels. Assisted dying raises some of the most profound ethical questions in modern medicine, many of which sit at the crossroads of autonomy, vulnerability, and societal values. Here are several core concerns. One, autonomy versus protection of the vulnerable. Two, one of the strongest arguments in favor is the right to self determination, to choose when and how to die in the face of unbearable suffering. But critics worry that some individuals, especially older adults, people with disabilities, or those lacking social support, might feel coerced into choosing death out of guilt, a sense of being a burden. 3, the role of intent in medicine. This challenges the traditional view that medicine is solely about healing and preserving life. Can a physician intentionally participate in hastening death and still be aligned with Hippocratical tradition? This introduces tensions around the moral identity of healthcare providers. 4, potential for slippery slopes. Some ethics fear that once assisted dying is legalized for terminal illnesses, criteria might gradually expand to include chronic conditions, psychiatric illnesses, or even existential distress. Countries like Belgium and Canada have seen shifts in eligibility criteria over time, prompting concern about safeguarding boundaries. 5, consent and capacity. Ensuring that someone is making a truly informed, voluntary, and competent decision is complex, especially if cognitive impairment, depression, or pain are involved. There is a real ethical imperative to distinguish between a genuine desire to die and a cry for better care or emotional supports. Six, impact on trust in healthcare. Could this change the patient provider relationship? Some worry that if physicians are seen as facilitators of death, even in rare circumstances, it might erode trust, especially among marginalized populations who already experience discrepancies in care. 7, cultural and religious diversity. End of life values are deeply personal and shaped by culture, faith, and experience. A one size fits all policy can be ethically fought unless it's designed with room for consequences or conscientious objection. Pluralism and inclusive dialogue. This debate doesn't yield simple answers. And may be that the point, if you'd like, we could explore how different medical associations have framed their ethical guidelines, or delve into case studies from countries with established laws. Certainly, here are a few real-world cases that illustrate the complexity and emotional weight of assisted dying decisions across different contexts. Okay, Tonya and Harmish Cooper. Now, this is a study that was done in the UK about people's illnesses and assisted dying, guys. So I'm going to go through this, through the paragraph for you. In a deeply personal revelation, Tonya Cooper admitted to giving her terminally ill 7-year-old son, Harmish, a large dose of morphine in 1981 to end suffering from stage 4 neuroblastoma. She shared her story decades later, now facing her own terminal illness. To advocate for legal reform in the UK. Her case underscores the emotional toll on caregivers and the ethical gray zone when legal options are unavailable. Then we've got another case, guys. Brittany Maynard, USA, Oregon, diagnosed with terminal brain cancer at age 29. Brittany moved from California to Oregon to access the state's Death with Dignity Act. She ended her life in 2014 using prescribed medications, becoming a prominent voice in the Right to Die movement. Her story helped galvanize public support for assisted dying laws in the U.S. and other U.S. states. Okay, and then we've got Adria Bowers, Netherlands. So another case in terminal illnesses. I'm going to go through that one too. Okay. A 29-year-old Dutch woman with severe psychiatric illness was granted euthanasia in 2018. Though not terminally ill, she suffered from chronic suicidal psychosis and depression. Her case sparked international debate about the boundaries of assisted dying, especially for non-terminal psychiatric conditions. Then we have Ellen and Jerry Gilland, USA, Florida. In 2023, 76-year-old Ellen Gilland was charged after allegedly shooting her terminally ill husband in a hospital at his request. Florida law prohibits euthanasia, and the case regenerated debate over legal options for those in extreme suffering. It also highlighted the desperation some families face when legal avenues are closed. Each of these cases reveals different facets of the ethical, legal, and emotional terrain surrounding assisted dying, from potential parental love and terminal suffering to mental illness and legal constraints. If you'd like, we could explore how these stories have influenced policy shifts or public opinion in their respective countries. Assisted dying laws vary widely across the globe, reflecting deep cultural, ethical, and legal differences. Here are some snapshots of where things currently stand. Countries where assisted dying is legal. Canada. Give me 1 second. Legal since 2016 under medical assistance in dying or MAID, that is MAID, initially limited to terminal illnesses. Now it includes those with grievous and heritable conditions, even if not terminal. Netherlands and Belgium, among the most permissive, both allow euthanasia and assisted suicide for adults, and in rare cases, minors. Belgium permits it for psychiatric conditions under strict criteria. Switzerland, assisted suicide is legal if the motive is unselfish. Organizations like Dignitas offer services to both residents and foreigners. Australia, okay. Hold on. Gotta fix these hooks. Okay, most states have legalized voluntary assisted dying for terminally ill adults. Victoria was the first in 2019. New Zealand, legal since 2021, following a national referendum, applies to terminally ill adults with less than 6 months to live. Spain and Portugal, both countries recently legalized euthanasia and assisted suicide for those with incurable or debilitating conditions. Colombia and Ecuador. Colombia legalized euthanasia in 2015 and expanded access in 2022. Ecuador followed in 2024 after a constitutional court ruling. Luxembourg legal since 2009 for adults with terminal or unbearable conditions. United States, assisted dying is legal in 10 states: Oregon, California, Vermont, and DC, but only for terminal ill adults with a prognosis of 6 months or less. Patients must self-administer the medication. Okay? You must be able to self-administer with a terminal illness. Okay, folks? Countries where it remains illegal or restricted. Germany, assisted suicide is not criminalized by organized provision is restricted. New legislation is still under debate. Okay. France and Ireland ongoing discussion and proposed bills, but no legal framework yet. UK, United Kingdom, recently passed a bill in the House of Commons, but it still faces scrutiny in the House of Lords before becoming law. Would you like a visual comparison of eligibility criteria or how safeguards differ across these countries that could help highlight the nonsense in how each nation balances autonomy and protection in Canada? Medical assistance in dying or MAID is governed by federal law and has evolved significantly since its legalization in 2016. Here is a breakdown of current legal framework. Eligibility criteria. To qualify for MAID, a person must be eligible for publicity funded healthcare in Canada, be at least 18 years old and mentally competent, have a grievous in irremediable medical condition, which includes a serious illness, disease, or disability. Okay. An advanced state of irreversible decline, ensuring physical or psychological suffering that is intolerable, make a voluntary request that is not the result of external pressure. Give me 1 second, guys. I have to get the rest of my notes apart here. Okay, provide informed consent after being informed of all care options. 2, two tracks of eligibility. Canada distinguishes between track 1 for individuals who natural death is reasonably foreseeable. Track 2 for those who natural death is not feasible. This includes additional safeguards and a longer assessment period. Methods of MAID: clinician administered, a physician or nurse practitioner directly administers a substance to cause death. Self-administered. Hold on a second. Self-administered. The individual takes a prescribed substance themselves. Less commonly used. Safeguards. 2 independent assessments are required. A written request must be signed and witnessed. For track 2, there is a 90-day minimum assessment period unless loss of capacity is imminent. Okay, final consent must be confirmed immediately before the procedure, unless a waiver of final consent has been arranged. Okay, guys, last page. Mental illness causes. As of now, individuals who sole underlying condition is a mental illness are not eligible for MAID. This exclusion is set to remain in place until March 2027 to allow further study and safeguards. If you'd like, I can walk you through how these laws compare to those in other countries, or explore ethical debates surrounding track 2 eligibility. Okay, guys, so that is B. And the reason that I did this one is to for everybody's FYI, because I believe that if someone has a terminal illness and it's not going to change, if they're in the right states, legal states where assisted dying is legal, then I believe in having a peaceful end of life experience. If someone is really suffering, guys, I think because I do hospice and end of life, I believe in somebody getting dignity at the end of life. If someone wants to go to sleep and then pass, that's fine. You know what? I have seen both sides of the debate for people's illnesses and such. I've seen a lot, and I believe that if someone's dying and their last wish is to go to sleep and not suffer or have medication to help them ease themselves, then that is a good discussion for someone's own choice. Now somebody has to be the one to say, to make that choice. Like I believe if someone has let's say for example end stage cancer, and let's say that they're in hospice care and they ask their hospice person to help to put them to sleep because they don't want to see pain. I believe in going that way. I believe going to sleep is the easiest way to help somebody pass. I mean, if they have a terminal illness and they're suffering with pain and they have the option for hospice care, then they need to take it. They need to sit with the hospice person and go through their wishes and wants before. I believe in giving somebody that kind of choice before it happens. Like have it written down in paper if you have time to. That's my whole choice of why I chose to be certified in end of life care. I believe in helping somebody make that choice. If you have time. And my whole purpose for being in this profession, guys, is to see people have dignity at the end of life. That is the only reason why I got certified in it, is because I want to be able to help somebody pass peacefully when they have to. Not suffer alone, not be in pain, but have the dignity at the end of life if they choose to. So, with that being said, that is B for the night. I'll be back on with C shortly. I'll see you guys shortly for C.